All right, welcome back. This is Mental and Emotional Problems, Chapter 10, and we're going to talk quite a bit about not just the specific problems that occur with mental and emotional problems, but also about the broader scale subject of the fact that the way people view mental health as a topic, and hopefully try to at least ease your mind a little bit that it's not something that that you have a negative connotation with, that you are crazy or insane or anything like that, but rather that it is sickness and it can be dealt with many times just like a physical illness might. So let's dive right in. All right, so on this motivator, I want you to write as many words as you can think of when you hear the term mental illness. It says here on your notes that you can use any part of your paper, write in different directions, sizes, go crazy. I mean, if you want to be an artist, that's fine. But we're talking about terms or phrases here. When somebody uses the phrase mental illness, what do you think? I'll give you a few minutes. All right. If we're using our book in this one, then we're going to do this. There may be times that we do go paperless. If this is on the website and you're viewing it via website, this is not something that you've got to worry about right now. But if we're using the book, our personal health inventory now is on page 237. This is not something that I want you to write the actual statement about, just number from 1 to 10. And remember, you're answering yes, no, or sometimes on that. And then it's going to ask you to check 3 that you might want to look at to work on after you fill out the survey. Same thing, I want to give you a few minutes to get that done now. So there's a lot of verbiage on this slide, but I really want to highlight just a couple things because, to be honest with you, we're going to look at the rest of it as we go throughout the PowerPoint. Right now, to highlight mental disorder, as far as the definition of the slide, and I'll give you a definition, a book definition, and you can, of course, also you can call this a mental illness or a psychiatric disorder, but by definition, and I'll go slow so you can write this down, it is a mental or behavioral pattern that causes either suffering or an impaired ability to function in ordinary life. One more time. A mental or behavioral pattern or anomaly that causes either suffering or an impaired ability to function in ordinary life. And as I said, anxiety disorders, somatoform disorders, hypochondriacs, affective disorders, all of this we're going to sort of detail as we continue along through this. These concepts you don't have to copy down, but just to sort of talk again about what we're going to hit on. Mental disorders are rooted in emotional, psychological, physical, or biochemical problems. Those are sort of subcategories of mental disorders. They can interfere with your normal functioning, with especially yourself. That can be with others or even society at large. And then finally, mental disorders can differ from person to person and episode to episode. This is very key in the way that doctors and physicians, psychiatrists, psychologists, which we're going to highlight the differences, subtle differences between those, in some cases, major differences, but how they can treat you and how they will go about treating you. So we'll move right along here. Continuing on the theme of the broad category of mental disorders, by and large, people that suffer from mental disorders are often identified by their inability to cope with life changes, demands, problems, or traumas. So when they're suffering from a mental disorder, this could be brought about. This is not just a genetic situation. There are those, and we'll identify those later. But a lot of times this is not just at the onset of life, but it could be as you begin adolescence, where a lot of you are right now, or if a major event happens in your life to cause that. We kind of talked about that with stress to a certain degree. If you move, if the boyfriend or girlfriend dumps you, if you lose a friend, or somebody says something in a bullying manner on social media, or some kind of cyberbullying episode, anything like that, that is traumatic, could cause a mental disorder. They're characterized not only as emotional disturbances, but also as imbalances in the brain. So a lot of times too, this is where we kind of dive into the chemical side of it, which is also real. And keep this in mind too, because I'm going to talk about this as I move through here. Whether a mental disorder is real or imagined, if the person believes that it's real, if there are changes in their behavior or social patterns, then it's real. As far as how you treat it, as far as how you are as a friend or a person of accountability, you have to think about it that way and react to it that way. I think that's important for you to remember. All right, here's something for you to write down. Every mental disorder is classified under two broad categories, and I'm going to try to underline those right now. I'm not great with the pen here, but organic or functional. And so when we look at these, we're going to try to start our verbiage and our language that way. They're either organic or they're functional. The first type, organic, is clearly caused by physical illness or injury to the brain. And if you want to write down specifically that it's a physical illness, I think that would suffice. Here's some examples: tumors, alcoholism, syphilis, meningitis, lupus, and stroke. The second broad category, and probably the one that we'll focus on more in this chapter, because remember, under organic mental disorders, we really hit a lot of those chapters later on, or we have already. Psychological or no clear brain damage. So for functional, if I'm going to write something down, I'm going to write that it's a psychological disorder. It results from stress, which we've already talked about, emotional conflict, fear, or poor coping skills. And then underneath these functional subcategories, again, the next slides are going to be focusing on these functional subcategories. You've got anxiety, somatoform, affective, and personality disorders. All right, another term definition that you need to be familiar with. Remember, we're under the functional category. This is a subcategory of anxiety disorders, which is a real, imagined, or persistent fear that prevents one from enjoying life. If you're looking down at your paper right now, I'll try to help you some more and read it to you one more time. Real, imagined, or persistent fears that prevent one from enjoying life. Think about that definition for a second. What does that bring on for us as far as how many people could be lumped into this category? I mean, I know at one point in my life or another, I could definitely include myself in this category. People that have anxiety disorders and that are prolonged are going to arrange their lives to avoid situations that make them anxious or fearful. I'll pause right here and ask how many of you have seen some of these episodes that are on cable that sort of highlight these phobias or these fears, and it is usually those are extreme situations, but it's nonetheless painful to watch people have to rearrange their lives to get around the thing that's really destroying their life, which could be anything, and actually would fall under one of these. Again, we're going to drop a little bit farther down the detail department and go into these other subcategories of anxiety disorders. There's 4 types. There's phobias, obsessive compulsive, panic, and post-traumatic stress disorders, PTSD. A lot of you familiar with the military, if you've had somebody with your within your family that's been involved in the military, has heard about PTSD. I'll get into that a little bit more later. It's not just a military associated disease, but that is something that sort of crops up, especially during wartime. right, so phobias. I like this slide. It's got golden bear colors. Write this down. It's a specific fear that's so strong that a person goes to extreme measures to avoid the object or activity. A specific fear that is so strong the person goes to extreme measures to avoid the object or activity. And it kind of goes through a list here, and you can go crazy with this. I saw this on Trivia Crack the other day, and I answered this correctly. I'm thankful for my education. Acrophobia is a fear of heights, and that is one of the phobias that the most people experience as far as people that have been surveyed or treated. Claustrophobia is a fear of enclosed spaces. Astrophobia is a fear of lightning. I tried to put some of the ones, the book highlighted a lot of these too, but stuff that, some crazy ones, but most of the ones we deal with on an everyday basis. Bathyphobia is a fear of depth. Dromophobia is a fear of crossing streets. Ophidiophobia is a fear of snakes. I'm sure a lot of you have that. I'll kind of go ahead and put my little snake picture right there. There we go. That's pretty bad. Pyrophobia is a fear of fire. And there's so many more, and probably even more since not just this book was created, but even books more recent. There's probably plenty related to technology now. Matter of fact, I've seen some on social media. There's probably one for social media. A person with a phobia may not be able to carry out daily activities. They may have been brought on by past experiences. And so when you're looking at a person with a phobia, and again, everything as far as the scope of vision here is how can we help? If it's not us, how can we be of assistance? If we are a friend, a family member, or somebody, an acquaintance that cares. So think about this as you're going through this. Don't just look at it in terms of yourself, but try to kind of think outside the box when it comes to how we can help, or how we can, if we can't help, who we can put them in contact with that can. I mentioned the shows earlier. One that used to be popular, and honestly, I don't know, I haven't watched it in a while, but Obsessed was a show about people with OCD. OCD is short for obsessive compulsive disorder. Jot that down on your paper. A person that is OCD is trapped in a pattern of repeated behaviors or thoughts. Trapped in a pattern of repeated behaviors or thoughts. Trapped in a pattern of repeated behaviors or thoughts. Sorry, I was being funny right there. But somebody that has OCD, really, they have persistence of obsessions. They're recurrent. There's unwanted thoughts or ideas that keep them from thinking about other things. Their mind is completely focused on the thing that's driving them crazy, and that is a figurative term. But they can't get away from that idea. So anything that's normal has to wait. You've heard people that would pick up a pen and tap it 3 times before they wrote on a piece of paper, and it can be something as simple as that, or it can be something that, like the hand washing thing where they're obsessed about that. And you say, well, that's not a bad thing, like the example says down here. Why is it bad to wash my hands 30 or 40 times a day? It's not bad to wash them 4, 5, 6 times a day. If you're a worker, it may predicate that you do it more. It may be, part of the deal for you, but and that's cleanliness. That's not bad at all. But we're talking about people that will rub layers of the skin off because they're not trying to do the habit of keeping their hands clean, or at least in their mind they may be, but overall it's a compulsion that they're never clean. And so when you're looking at these kinds of things, if it's gone to the part where there is physical harm or danger to the person, it's probably past what we can do to help as an individual. So we need to take the next step and make a call and try to get them connected to somebody that has that potential to help them. And I will say it's not difficult as far as trying to find that, as far as getting online and making a connection there. Something that's become very common in the last decade, 2 decades, is panic disorders. Panic disorders are, and you would write this down and it would be good, a condition in which fear or anxiety prevails and gets in the way of functioning and enjoying life. Fear or anxiety prevails and gets in the way of functioning and enjoying life. And of course, you all know or have heard of the panic attack, which, if you're looking at a severe panic attack, then you're talking about trembling, racing heartbeat, shortness of breath, fear of losing control, even dying or fear of dying. Now, except for the last couple of those symptoms, the good news about those is they're mostly physical in nature. So you can keep an eye on those things. You can track those sort of things. Depending on how close you are with the individual, you may know that they have a predisposure to panic attacks, or they have a panic disorder. And so that's something that you can look for. And there are certain things that you can do to help, even if you're not a professional. However, I would still caution to say that the best thing to do in those cases is to isolate the person, get them by themselves. You can try some breathing techniques and those kind of things with them. And if you don't feel comfortable in doing that, get them with somebody. And in our building, if we're at school, a teacher, a guidance counselor, a STARS counselor, or anything of that nature would be somebody that you would try to connect them to, even an SRO, as soon as possible. I alluded to this one earlier. PTSD, really kind of a hot button topic because we are in wartime, or have been in wartime, continue to be. And I did say earlier, it's not just connected to the military, but when you're looking at people that have had a high stress job that entails trauma, or the potential for trauma, then it doesn't, and again, this doesn't automatically mean that they're PTSD victim. It just means that they're at high risk for it. So what are we looking for with post-traumatic stress? A person has witnessed or experienced a traumatic event. It feels severe, long-lasting, with the side effects. Okay, so let me get my eraser. I've messed that up. Let's try that again. Witnessed a severe or a traumatic event that feels severe and has long-lasting side effects. And so, again, some of these symptoms can be physical, but in this case, a lot of it is psychological, or it happens during the dream state. So you've got flashbacks, nightmares, emotional numbness, dreams about the event, obviously, sleeplessness or insomnia, feelings of guilt, and so forth. So what is tougher about identification of PTSD is the fact that if they don't talk about events or those kind of things, it really has to be a very intimate situation for the person to know about it. It has to be within the family or something like that if you're talking about nighttime situations. But if you've got the person talking and they're really discussing this, and it's something that they're wanting to talk about, that's a great sign. Again, and I know I sound like a broken record here, but it's okay that I do. It's probably beyond our intellectual capabilities, and it's something that we need to talk to a professional about. So we would seek help that way. All right, somatoform disorders is an illness in which a person complains about certain disease symptoms but has no physical evidence of disease. Write this down. An illness in which a person complains about a certain disease or certain disease symptoms but has no physical evidence of the disease. This one is tough to identify, tough to help with, honestly, tough to swallow if you're the friend or the acquaintance or somebody that's connected to them, because you probably feel inadequate about knowing how to help. We as human beings, we want to see something that's tangible. I want to be able to see it and touch it. If I fell off the skateboard and scraped my knee, there's a burn there. I can treat that, but with this deal, it's very hard. And I want to give you the biggest disease example that I can give you is the hypochondriac. So go ahead and jot this down too. It's a very similar definition, but it's more specific. A preoccupation with the body and fear of presumed diseases that are not present. A preoccupation with the body and fear of presumed diseases that are not present. Let's see if I can explain this. Let's say that a person has a fear, a hypochondriac in this case, that there's diseases that they have obtained that's either minutely possible or not possible at all, based on our climate, based on our geography, based on our surroundings. A lot of times we're sort of intelligent enough to figure out that if it's let's say it's a disease that could only thrive in a third world living environment, and nobody, luckily, where we're at is in that situation. So if they're saying that they have this disease, it's probably not very likely. Now, again, I want to stress what I told you about 10 or 15 minutes ago in an earlier part of this discussion. And it's this. What if that person believes so strongly that they have a disease that they change the pattern of their life because of it? The way that you treat this is the fact that you have to allow that person to work through it with a professional usually, and it is not your job to let them know that they're crazy or they're insane or that they don't have the disease. Instead, it's your job to be supportive and to try to help out in any way that you can. And this is tough. This is not normal, but nonetheless, it's because it's considered a disease, a disorder, even though it's presumed, even though in our minds it's made up or make believe, the key is the person believes that it's real. And because they believe it's real, it has to be treated that way. All right, I'm going to pause and ask a question right here before we move to affective disorders. Which category are we in right now? Remember that mental disorders are really divided into two categories. This is a subcategory of one of those two. So I'm going to pause the slide and let you answer that question. Hopefully you said functional, because we're still under that. Remember, there are organic disorders and functional disorders. And we are learning more about the functional disorders. And I restate from earlier that organic disorders will be readily identified in other chapters. We have a chapter devoted to alcohol. We have a chapter devoted to STDs. We have a chapter devoted to some of those different organic disorders. So they're not forgotten, but we're really focusing on some of the others right now, so that we don't overkill the organic part. These are affective disorders. They're also known as mood disorders. That's probably what they are known more for in society. Illnesses that have with organic causes, and that's why I pause on this one sort of for a reason, because they can be misconceived as organic. The reason they're not is because they relate, second part of the definition, they relate to emotions and may involve mood swings or mood extremes that interfere with everyday living. As far as the definition here, hold off on writing this one in particular, because we're going to look at clinical depression and bipolar disorder as sort of the banners for affective disorder. Okay, write this down. Clinical depression is feelings of sadness, hopelessness, or despair that last for more than a few weeks and interfere with daily activities and interests. Now, I need to pause right here, because we've already talked about the stages of loss in the stress chapter, and I highlighted the fact that stage 4 was depression. I also highlighted the fact that that stage as it runs its course, moves into stage 5, which is acceptance, which is where you want the individual to be or yourself to be in the stages of loss. This is a whole different ball game. Now I can say that in stage 4, if they get stuck in stage 4 of the stages of loss, it can turn into clinical depression. But this is a step up from if there's such a thing as calling it regular depression. This is a step up from that. I'll say it again so that you make sure that you've gotten it written down by now. Feelings of sadness, hopelessness, or despair that last more than a few weeks and interfere with daily activities and interests. The depression often runs in families, can be genetic in nature, but it can be triggered or brought on by a life event or accumulated stressors or traumas. Not necessarily something you have to write, or unless you want to just write, can be genetic or also brought on by life event. But either way, it can be treated the same way. It needs to really be known up front by the person that is treating the illness so that they can there's various techniques that they'll use to try to do that, try to work with you on that. And that's something that's good. The more information that any time a psychologist, psychiatrist, neurologist, social workers, these people that we're going to talk about late in the chapter as far as who deals with what, the more information that they have as far as yourself, as far as background, hereditary information, the better, so that they can attack it from different angles. Right now, bipolar disorder. Next to bipolar disorder, you can put AKA. I'll see if I can do this with my pen here. Because people call it this as much as they call it bipolar. Manic depressive. In the medical community, they're interchangeable. The definition starts here. It is a psychological disease that ranges from depression to happiness to mania. Some people may have only one of these 2 phases of disease, so when you're looking at it in terms of that, it could be one or the other. I cannot stress enough with this disease that it is not, and none of them are anything to mess around with, but if there is any hint of the symptoms of this disease being present in yourself, in a friend, in a family member, you do not wait when you're talking about seeking help for bipolar disorder. We're going to talk about suicide later on. It's a tough subject to talk about, but suicide prevention is part of what we're talking about right now. If I can identify with someone, and here's the thing, if you're wrong about somebody potentially being bipolar, what's the worst that's going to happen? Somebody's going to be mad at you, or somebody's going to be upset with you. I tell you what, I'll take my chances with that if I can help save somebody that may have it, because bipolar disorder left alone, unfortunately, can lead to suicide. As a matter of fact, a lot of times post-suicide, when they look back at those things and those situations, and they talk to those people that are closest to them in their lives, and they kind of get a frame of reference for what the person was going through, they could have very well been diagnosed as bipolar or post-diagnosed with bipolarism. And that's a scary thought, and it's okay to be a little fearful of this. If you have a friend that is exhibiting some of these, it's not okay to not do anything about it. Honestly, when you look at this slide, personality disorders, it could be a chapter in and of itself. In the current day and age that we're in, unfortunately, we don't have time for that as far as our time frame. So, but I do want you to have an understanding of what it is and what it includes. And then if you break off from there and start learning a little bit more about it, then, and I'll be honest with you, if you identify with a personality disorder, you could probably teach this portion of the class, and we may pause or stop here in a minute and talk about some of these situations that that either, if you feel comfortable with that either you've been involved with, or a classmate or family member or friend or whatever. But nonetheless, as far as what it is and write this down, a variety of psychological conditions that affect a person's ability to get along with others. You can stop right there as far as what the definition entails. A variety of psychological conditions that affect a person's ability to get along with others. It says they may often be at odds with others, not seeing both sides of an issue, no apparent or distinct signs and symptoms. That's the tough part, because it's tough to identify. The types include antisocial personality disorder, passive aggressive personality disorder, schizophrenia, which is really a whole nother level as far as the depth of the personality disorder. There is debate among the scientific community still about multiple personality disorder, and whether that is under the envelope of schizophrenia or its own. Nonetheless, when you talk about schizophrenia, the phrase split mind sort of identifies that, where a person is sort of taking on their own personality as well as an inherent made-up personality that could be from their past. It could be from an experience or a trauma or something like that brought it on. But it's a very tough one. It's not that tough to identify as the stages advance. It's very tough to treat, but it's important that we, of course, get an understanding of it, a grasp of it, so that we can be encouraging and helpful in these. And then the last two categories, which could branch off and have their own chapter, is attention deficit disorder and ADHD. I feel like you guys have an idea about that, because as it's so often diagnosed, there's somebody probably within your family or outside of your family that has ADD or ADHD. The good part about that is that there is proper medication for it. The bad part about that is it's some of the most abused medication when we're talking about that. And again, there's a fine line. It's tough to be a parent this day and age, because it's tough to know the difference between a child that is just hyper and can use extra chores or physical activity or whatever it is, and a child that crosses over into having either ADD or ADHD. The way I try to make sure that I balance myself as a parent and to you as a teacher is to just suggest to you that if it's come to the point where you're not sure and it's beyond your intellectual capability, have somebody that you trust, and maybe it takes time. Maybe you shop that around, but have a professional that you trust test them out and see what they think, and maybe even do that with a few people. It's not something that you have to rush through. It is something that you want to get right. The third section of our chapter here talks about suicide prevention, and in order to successfully prevent a terrible situation from occurring, you got to know first about what the definition of suicide is. Grab your pencil and write this down. Suicide is the act or instance of intentionally killing oneself. I'll read that once more. The act or an instant of intentionally killing oneself. Don't write this, but I thought, I was looking at the dictionary on my other screen, and I thought it was interesting to look at some of the other ones that accompany that definition. And it talked about the destruction or ruin of one's own self-interest, and used that example of professional suicide to involve in legal practices or something like that. And we do use that term in more than just the finality of actually killing yourself. But when we're talking about this chapter, we're really focusing in on that. We're going to talk about suicide as a whole, but we're also going to talk about cluster suicides, which are even more scary. On these concepts, it says suicide is a complex behavior that usually involves many risk factors such as drug abuse or mental disorders. So that's how you tie that into this chapter. Here's the key, and this is for yourself, this is for you as a friend, as a family member, or as somebody that has a vested interest in another person. People considering suicide do exhibit certain warning signs, and we're going to go over each one of those and talk about them a little bit more in depth. So when you're looking at suicide risk factors, you're talking about depression, isolation, chronic anger, substance abuse, violence abused, prior attempts, firearms in the area, jail time, history of mental disorders, exposure to other suicides. It can be one of those. It can be a combination of those. As far as for your writing, you might jot down a couple of those. You have an idea now of what depression is. You have an idea of how to identify it, especially if it's somebody that you're close to. The isolation thing is, especially if this is somebody that's normally like that, they're very independent, then it may be a little bit different. But you have the common sense to figure out if this is somebody that's an outgoing person, and lately they've been putting themselves in a situation where they're really becoming a loner, and they're sort of cutting off communication with other people. That's something that you really want to look into. I'll say this once for this section, but I've said it several times in the chapter. If you feel like it's bigger than you, that's not a problem, unless you don't go talk to somebody about it. And again, I can't stress enough that if this makes you nervous because you're afraid your friend's going to get mad at you, when you think about the finality of what happens with suicide, that should encourage you and motivate you to go talk to somebody about it. Because you don't want that weight on you if you feel like that's something that's a possibility. Chronic anger, we talked about that in an earlier chapter. That means ongoing and consistent. So not somebody that has an episode, but somebody that's doing it all the time. Drug abuse, obviously. If they're not prone to violence, and they, and again, even if it is isolated, if it's associated with one of these other ones, then that's something you would look into as far as trying to get help. Obviously, some of these are obvious. Prior attempts. And firearms in the area is something that you may not know unless you're really close to them, or it's a family member or something like that. And obviously, if some of these other things are happening, that needs to be addressed immediately as far as taking away that access. If they've gotten not just jail time, but if they've gotten in trouble over something, and their response to it is a downward spiral for a longer period of time, that's something to look into as well. And in this chapter talks about mental disorders. So if you know for a fact that they're bipolar or one of the ones that's sort of related to suicide in and of itself, and then they exhibit one of these other ones, that's something to worry about. Exposure to other suicides is also something that, we don't think about it enough, but especially if it's inside the family and then that person feels like, things aren't going for them, and they look at the other person that's checked out, and it's just something that's scary, and you really want to be monitoring that. We may be using a book. This may be something I decide to do. In this case, if we're paperless, we're not going to look at some of these warning signs. But I will say this: when you're looking at warning signs, there are physical and verbal warning signs, and then there's signs that you would really have to be close to the person to sort of figure out. Or if you were smart enough, not smart enough, if you were honest enough with yourself, and that was something that you were going through, obviously my suggestion would be to make sure that you talk to somebody. But what it does say is if you or a friend exhibit any of these or several of these signs, the likelihood of an attempt could be very high. And this is something that you want to make sure that you do. If I am paperless, in this chapter, or if you're looking at this on my website, just Google suicide warning signs. You're going to get plenty of information on that, and really focus in on the physical ones and verbal ones, because those are easy as far as pointing them out and knowing them. They're going to be easier to see, especially if you know the person well enough to know that there's been a traumatic event recently in their life. This slide's got a lot of info as far as suicide and suicide prevention goes, but I think it's important. I really like this first line. I'd like for you to write this down. Suicide thoughts are temporary, but death is permanent. And I think if you're talking to the person, you're really trying to reason with them. That's one thing that you look at is that if they're going through a rough patch, help them, talk to them, ask them questions. Well, let me move to the next bullet, and I think it sort of talks about what I'm saying here. Take any and all talk of suicide seriously. Listen. Don't just talk, but listen, and really listen. Don't just hear them talk, but really listen and give them support. Be calm, be patient, and be understanding. Write this down. Talk directly, openly, and freely, and allow the person the same courtesy. Don't freak out if they use the word, if they talk about a plan. If they're talking about those things, it's good. It's obviously in the big picture, it's not good, but as far as them communicating with you, it could be a cry for help, and you can't get on to them for it. You can't get mad at them about it. You don't want to push them in that direction, but at the same time, you can't be afraid to talk to them about it. Analyze the situation, and so the more that you know, uh, the more that you're able to pass on to somebody that may uh, be a professional in this area and can help you out with it. Stress that problems are temporary. Stress that you'll go with them to seek professional help. A lot of times, that might be in the cry for help. That might be what they're looking for. They need you to be with them. They need to know that you're their security blanket, and you got to be willing to drop everything in that. And most anybody that's got as far as humans go, a lot of times good-natured people are going to do that. But it's something that you want to make sure that you make a priority. Most suicide survivors are grateful they didn't die. There's so many stories of people that made those attempts and were unsuccessful, thankfully, and now they're having a great success and rebound in their life. And those are readily available online too. Those are things that you can talk to your friends about, look up, and really discuss. And at first, I think it's good that they identify, or you, if you're the person, with people that has been in the same place as you, but has come out of it. Ask them if they've made a plan. Don't let them near drugs or guns, and don't leave them alone. If they've made a plan, that has to be a priority. You have to stay with them. Make a call again. Even if you have to go to the bathroom to do it, if you have to excuse yourself from the room for a minute, and you know that there's no apparent or immediate danger right there with them, make a call. They're going to be mad at you. They may. But again, suicide thoughts are temporary. Death is permanent. If their reaction is to get mad at you, but they live, down the road, they're going to obviously change that perception, and they're going to be much happier, and they're going to be thanking you for it. So be confident in that, and trust that, and trust that if it's something that may be bigger than you and you need to get help, never agree to keep it a secret. All right, as we finish up here, this is the last section. We're going to talk about a few terms that will get you help, or the person that you're closely associated with help, and sort of tell you the difference and how you might identify with each one of them if you were trying to get help. Before we define them and sort of separate each one of them, it's important to note a couple things. Number one, and this is something that you need to get across to your friend or family member, seeking help from a mental health professional does not mean a person is weak or crazy. Write that down. That's good to remember. Seeking help from a mental health professional doesn't mean you're crazy. Serious disorders are not something you can sort out on your own or even with a close friend. You need professional help. As silly as it sounds from a physical standpoint, if somebody has an abrasion or they cut themselves with a laceration or something that requires stitches, unless you're farther along than I think you are in the medical profession, you're not going to stitch them up. You know, you're not going to apply the aid necessary to help them get well. It's the same thing with this, and you've got to think about it that way. Don't be afraid to ask for professional help. And another thing is this, and a lot of times you see this with in a socioeconomic situation where the person's not doesn't have any money. That's sort of the excuse that they make for not getting help. It's going to cost too much. I don't want to put that burden on my family or whatever, or myself. But a lot of times, guys, the cost can be adjusted, and these professionals are willing to do that to get you the help, especially immediately, that they need. And then that's something that you can worry about, or not worry about, but you can take care of later on. Again, when you stack finances up against a person's life, usually there's no question as far as that goes. They may use that as an excuse, but you've got to push through that and sort of reassure them that that's not an issue. Okay, here we go. When you're looking at the different kinds of help, this is how you identify each one and sort of the difference between each one. First, a psychiatrist, if you'll write that down. On a psychiatrist, that is a medical doctor who specializes in diagnosing and treating mental disorders and can prescribe medications. So sort of highlight the fact that they're a medical doctor and that they can prescribe medication. Their methods are psychotherapy, psychoanalysis, or medical psychotherapy. And so obviously these people are going to dive a little bit deeper into the situation, one-on-one most of the time, or if it requires more people, they can bring them in as they see fit. There may be an initial meeting where they sort of figure out the background on it, but they can go beyond just a conversation. They can actually prescribe medications if that's the necessary means to the end to try to help the person out. But when you're looking at the other ones, a neurologist deals just with the brain and organic disorders. We've talked so much about functional disorders in this chapter because we're going to talk about organic disorders in other chapters. And so when you're looking at that, that's where the neurologist would come in. Of course, they're obviously able to do surgery and those kind of things if it's necessary, but that's their area of expertise. A clinical psychiatrist, a counselor, or a social worker are all involved in that. And you might want to jot down next to social workers that the difference for them is their availability. They're able to, instead of you coming to an office, they're able to go on site for the family or go to that home and help out. And a lot of times it's a domestic situation where social workers can be very beneficial. So that sort of gives you an idea of the different types, depending on what the problem or situation is. And listen, you really still don't have to know that. That's something that you can call and get directed to the right help that you need. The key is the fact that they're professionals and they can really help us out in a lot of these situations.